Well, welcome to this quarter's Pediatric MS Navigating Your Journey program. Really glad to have you here. My name is Krista Harding, and I am a senior manager on the community engagement team at the National MS Society. As we get started today, we want to remind you that the Society's vision is a world free of MS, and our mission is to cure MS while empowering people affected by MS to live their best lives. We also want everyone to feel comfortable coming to the National MS Society for support. So for that reason, we share our inclusion, diversity, equity, and accessibility statement at the top of our program, which is that we amplify the voices of all people affected by MS and celebrate our differences in the drive to end MS. We affirm the space for everyone to express their perspectives, fueling our vision with innovative ideas and insights. We commit to advancing inclusion, diversity, equity, and accessibility within our workforce and across the MS movement. So, a brief overview of pediatric MS. Let's start with some general information about MS. Before you or your child were diagnosed with MS, you may not have known anyone with MS, or you may not have even heard of it before. According to Atlas of MS, there are at least 30,000 children under the age of 18 living with MS globally. So what exactly is MS? MS is a disease of the nervous system, which includes your brain, the spinal cord in your back, and your optic nerves, which connect your eyes to your brain. In MS, the body accidentally attacks normal cells called myelin, and when that's damaged, it's difficult for nerve cells to send and receive information to and from the brain. One way to imagine this is to think about when a phone charging cord is damaged. If the outside coating isn't doing its job, the wires underneath might not work as they should, and charging may become slower. So, like the charging cord, damage to myelin may slow down the messages your brain is sending to the rest of your body. These attacks produce something called lesions, which can cause symptoms in MS. We don't know yet what causes MS, but researchers are working hard to figure it out. We do know that women are 3 times more likely to have MS than men, and that MS is more common the further away you get from the equator. We know that you don't get MS directly from your parents, but that some of your DNA, called genes, may make you more likely to get MS. In fact, if someone's mother or father has MS, their chance of getting it themselves is just 1.5%. And if their sibling has it, their chance of getting it themselves is 2.7%. Having low vitamin D levels, being overweight as a kid, smoking or living with someone who smokes, or having been sick with mono could also make you more likely to have MS. However, it's important to know there is nothing you or your parents did that caused you to get MS. Scientists believe that getting MS is caused by a combination of factors, and many of them are completely out of your control. There are 4 types of MS, but for young people, relapsing remitting MS is most common. People with relapsing remitting MS often feel fine, but then have periods where their symptoms last more than a day and feel much stronger. Those periods are called relapses, but some people call them exacerbations, attacks, or flare-ups. All these words mean the same thing, a time when your MS makes you feel worse. Even though relapses last longer than a day, you will feel better once they end. Most young people recover well from relapses, and relapses don't necessarily cause permanent change. There's nothing you did wrong that made you have a relapse, and some medicines can help you manage them. MS can make your body feel strange, and everyone's experience with MS is different. Sometimes your vision might become blurry, your hands might tingle, or your foot feels numb for a while. Some of you might feel really tired every day or like you can't focus at school, and others might feel sad or worry or be in a bad mood a lot. Maybe you feel a couple of these together, and maybe they are symptoms that come and go. All of this is normal with MS. There are things you can do to help your body feel good, like eating nutritious foods and being active. And even though we don't yet have a cure for MS, excuse me, there are medicines you can take to help, both for your body and your mind. To treat your MS, your doctor might prescribe a disease-modifying therapy. The goal of these medications is to prevent MS from getting worse by preventing new damage, those lesions we talked about earlier, from being formed. The medicine might not make someone feel better, and because of that, they might not want to take it sometimes. But it is constantly working inside their body to help stop them from having new changes or relapses in the future. They may not even notice that it's doing its job, but it is. MS medicine will work best when someone starts taking it as soon as they find out they have MS, and continues to take it regularly as prescribed by their doctor. Because everyone's MS is different, medicines work differently for each person, too. So your doctors might want to try out a few different kinds right away or in the future. No matter which one you choose, the best medicine for you is the one that you, your parents, and your doctors decide is the right fit to help you feel as good as possible. If you are a young person living with MS, I want you to know that the way you feel about your MS treatment matters. Your doctors want to know how you're feeling and to hear about your experience with your MS medicines. Your opinions matter, and I would encourage you to be an active part of your own care team. Now, let's move on to our featured presentation. I'm pleased to introduce today's speakers. Joining us tonight is Dr. Kelly Jones, a pediatric neuropsychologist from the Kennedy Krieger Institute, and Dr. Haiwen Chen, a pediatric neurologist from Johns Hopkins Medicine. Welcome.
Thanks so much for having us. We wanted to do a little introduction of ourselves. I'll go first, and Kelly will follow. As Krista mentioned, I'm Haiwen Chen. I'm a pediatric neuroimmunologist at Hopkins. I actually did my training, my residency, and my fellowship at Hopkins. And the reason I went into pediatric neuroimmunology is that at the time of my training, we actually did not have a pediatric neuroimmunologist at Hopkins. And there was really a significant need for someone to take care of these patients and someone who had the
You got muted.
Sorry.
Yep.
Somehow I muted myself by accident. So yes, I went into it in part just to kind of fill this patient need because they were coming, to the hospital and they needed someone to work with them. And then I also became really interested in understanding the mechanisms of disease. And so I actually largely do basic science research in the lab to try to understand the pathophysiology of how the diseases causes symptoms in our patients.
And I'm Kelly Jones. I'm a pediatric neuropsychologist, at Kennedy Krieger Institute in Baltimore. Historically, my specialty has been in acquired brain injury more broadly. So I take care of patients who have been impacted by a brain injury, whether that's traumatic brain injury or another type of acquired brain injury. And I work with patients across settings, whether that's inpatient rehab or long-term follow-up. I got into this because Haiwen presented me with an opportunity to start following these patients after we had worked together on some previous patients. So over the past 3 years, been specializing more and more in these pediatric neuroimmunology conditions, and have been collaborating with Haiwen to best support our patients at Hopkins and Kennedy Krieger. So we're working together to understand this disease better, to provide more well-rounded treatment for our patients. And it's been really enjoyable to learn about it and to get to know patients and families.
All right. So tonight we're going to be talking about academic considerations for pediatric onset MS, which we will often abbreviate as PALMS for short, just to decrease the number of words on each slide. Okay. So I think if you're here, I'm probably preaching to the choir about why we need to talk about this. Pediatric onset MS refers to, as Krista mentioned, MS onset before the age of 18. It's seen in about 5% or so of all people who are ultimately diagnosed with MS. And for the most part, pediatric onset MS affects children between the ages of 14 to 18 years old. These are really formative years for educational and social development. And thus, we are really trying to address academic considerations that are really unique and particularly important for this group. This is kind of a general outline of our talk this evening. We're going to talk about how specific types of MS symptoms can impact academics with a focus on cognitive and motor symptoms, as those are often, not surprisingly, two of the main types of symptoms that we address. With that, the role of neuropsychological assessment in evaluating the needs of our patients. Kelly is going to talk about how that then leads to different types of school supports, including 504 plans and IEPs. types of example accommodations that have been recommended or suggested for different types of symptoms that patients have, and then thinking about preparing for college. Okay, so to start with, I think no one's surprised that cognitive involvement is a key player as the brain is really affected in MS for a large number of people. So these are actually images of lesion frequency maps aggregated from 29 different patients with pediatric MS. Here, they're presented in different orientations. On the most left are these axial cuts, in the middle, the sagittal cuts, and on the right, the coronal cuts and lesions are the intensity of each voxel in the overlay actually represents the frequency of lesions at each of these locations. And on the top row is kind of like the higher part of your brain, and on the bottom row is the lower part of your brain. The higher part of the brain, those areas are generally important for higher order cognitive function like speech, learning, emotions, planning, initiation of movements. And the lower part of the brain generally is actually really important for coordinating those functions with the rest of your body. Onset of MS during childhood is actually usually associated with a higher volume of brain lesions, particularly in the first few years of disease relative to adults, because kids with MS tend to have more active inflammation. And this may potentially contribute to why children with MS are ultimately found to be more at risk for developing cognitive symptoms. So, what are some of the cognitive impairments or cognitive symptoms that are common in people with MS? So these include speed of information processing, memory, visual motor integration, and attention. Additionally, language, reasoning, and executive functioning can also be affected. And specifically for kids, cognitive function affects about 1/3 of children with MS. Krista, if you advance a little every now and then, I have some animation in the slides. Sorry about that. And so we suspect that it may affect children more because they experience the disease during a critical period of development. This is actually a graph from a study, which I believe actually was conducted in Sweden, longitudinally looking at a specific form of cognitive function, specifically information processing efficiency in individuals with pediatric onset MS, which you can see in the kind of greenish gray bar, versus adult onset MS in the tan line over decades. And basically along the y-axis, the higher the number, the higher the efficiency and the overall better cognitive function, or this measure of cognitive function. And what they found is that in adulthood, patients with pediatric onset MS actually demonstrated a more rapid reduction in their efficiency at information processing over time, and were more likely to experience cognitive impairment than those who developed MS in adulthood. That cognitive impairment can lead to reduced quality of life, reduced social functioning, and reduced employment. And we know that broadly, even outside of MS, mood and fatigue can really also contribute to cognitive impairment, but especially in MS, because mood and fatigue are such prominent symptoms, they can really make this whole cognitive impairment situation worse. And all of these really altogether contribute to what our patients often remark as being invisible symptoms, that while they don't look disabled, they feel that there are significant impairments on how they're able to carry on in their daily lives. And in a lot of these cases, we'll be talking about in school. So on the more visible side, motor symptoms also have really big impacts for patients with MS. If you think about the fact that when kids go to school, they have to be able to get around school, to get to their classes, to get to activities. It may really also result in difficulty with certain tasks like writing or other fine motor skills that they're able to do. This is because those lesions in the lower part of the brain, as well as the lesions in the spinal cord, can lead to motor symptoms like arm or leg weakness, spasticity, tremors, and difficulty walking, as well as overall difficulty with coordination. over time, if MS is untreated, patients develop significant disability. And I know there's a lot of lines on this graph, but if you first look at the black and orange lines, this is from tens of thousands of kids that were diagnosed at different decades over the last 3 or 4 decades, and looking at the proportion of them who remain able to walk independently without assistance from a cane, a crutch, or a brace over decades from their diagnosis. And early on, if we're looking at pre-1990s in the orange line, and then even into the 1990s in the black line, we see that particularly around 30 to 40 years of living with MS, most individuals develop difficulty walking independently and need at least some form of support. The good news overall is that in more recent decades, most kids with MS no longer ever develop that level of disability. So if you look at the blue line from the most recent, the 2000s, we actually see that the majority of them never reach that stage. And in the graph on the right, we kind of have the reason why, because we are actually far more quick to start kids with MS on disease modifying therapies. So on the y-axis here, you can see the proportion of patients over these decades that are or time to starting them on these disease modifying therapies is really decreased. And not only that, but the time to start on particularly high efficacy disease modifying therapies have decreased. So while we will not focus these as much or on these other symptoms as much, these are a list of other common symptoms of MS that can certainly have a lot of significant impacts on patients' daily lives. These obviously include things like fatigue, which I know has been something brought up in past programming, pain and the sensory, numbness, tingling sort of symptoms, visual symptoms, depression, bladder and bowel dysfunction, as well as speech difficulties. At the end of the day, we know that each individual is unique. They're different. They have different strengths. They have different weaknesses. And as such, MS can really affect each individual very differently. And so as such, we really have to focus on how to develop individualized plans to support the needs of each of our patients effectively. And so with that, I'm going to turn this over to Kelly.
Yeah, thanks, Haiwen. So just to continue on that point of MS being a unique disease and every child having a unique presentation, that's where I feel that a neuropsychological evaluation can be really helpful in determining how symptoms impact a child at the individual level. So for those of you who are not familiar with what a neuropsychological assessment is, that's what I do as a neuropsychologist. And these are comprehensive evaluations that take a really deep look at a child's cognitive skills, in addition to their fine motor skills, their emotional, their behavioral functioning, and their academic skills. So it's a whole day usually of testing where we dig really deep into these areas of function and to see if they're having any consistent difficulty across any of these domains. So you can see we look at things like their IQ, their reasoning, their language skills, their visual spatial skills, their attention, their memory, executive functioning, fine motor, and emotional functioning. Because we know that some of these things could be impacted, all of these things could be impacted, none of these things could be impacted, and the evaluation just gives us a good idea for each child what their areas of strength and weakness are. So, the approach that we take at Johns Hopkins and Kennedy Krieger is we try to do testing for our patients soon after diagnosis. And we do this for a number of reasons. One is we can identify any cognitive changes that might already be occurring soon after diagnosis. As Haiwen mentions, oftentimes the cognitive difficulties don't become more impairing until later in life, but there are, depending on where lesions are in the brain, there can certainly be cognitive complaints early on. So we want to catch those. And sometimes those are subtle changes that might not be noticeable in day-to-day functioning, but our measures are sensitive enough to pick them up. Another important thing that we're screening for is mood and anxiety. And this is really important soon after diagnosis because children and adolescents are dealing with a new diagnosis, what that means for them, as well as just that underlying increased risk of depression that comes with the disease. So oftentimes we're referring our patients to our psychology colleagues to work with them for not often long periods of times, but for a couple months to help them adjust to this new diagnosis and what it means for them. The other reason why we like to see our patients soon after diagnosis is we can establish a cognitive baseline for them so that we have a place to start for monitoring over time, since we know that there's risk for cognitive decline with future relapses and as time goes on. And then related to this presentation tonight, one of the big products out of a neuropsych evaluation is you're getting individualized recommendations to support that child across settings. And I always say that a child's job is to go to school. So the biggest thing that we're doing as pediatric neuropsychologists is making recommendations to support whatever cognitive or emotional weaknesses that they have in the school setting. So what we're going to talk about tonight are types of school supports that are available here in the United States and talk about what that looks like from elementary school all the way through college and give some really specific examples of some accommodations that might help your child. So, in public schools in the United States, all the way from kindergarten through graduation, there are two different plans that are available to support children with disabilities. There are 504 plans and individualized education programs, also known as IEPs. And any public school in the United States, all of public schools are federally funded, they must have this available to a child with a disability. And we'll go through what each one of these are. In private schools, they're not mandated to provide the same level of support. However, many of them do offer informal accommodations voluntarily, but it's not to the same level of formality as you would have in a public school system. And then when a child gets to the college or university level, again, all universities are legally required to support a student with a disability. So the two big ones that we have at the, middle school, elementary school, high school level are 504 plans and IEPs. And we're going to talk about what the differences, what they are and what the differences are between the two of them. So the kind of first level of support is a 504 plan. These have been around for a while. They were based on the Section 504 of the Rehabilitation Act of 1973, which was a civil rights law that was put in place to protect individuals with disability from discrimination in any program that receives federal funding, which includes schools. And the main goal behind this law is to ensure that students with disabilities have equal access to education. So it's a way to kind of level the playing field to help remove any barriers that are associated with their disability. So it is a formal plan. But what it does in comparison to an IEP, which is special education, we'll talk about that, is it is just providing reasonable accommodations to again remove those barriers from learning to ensure that that child has access to their academic activities as well as any non-academic and extracurricular activities. As I mentioned, it does not provide specialized instruction, so it is not special education, and it cannot modify the curriculum because that's special education, but it's a way to provide accommodations and supports for any numbers of symptoms that a child with any disability has. And what counts as a disability is any physical or mental impairment that interferes with a major life activity. And for children, again, that major life activity is attending school. And it requires documentation. So oftentimes parents are having forms signed by physicians, neuropsychologists to provide documentation to the school of the disability and the impact that disability has on their functioning in the school setting. So this is a plan that's created by the school team. I always remind parents that they are the most important part of the school team. So it's created in collaboration with teachers, staff, counselors. So parents play a big part in developing the 504 plan and advocating for the needs for their child since they're the ones that know them best. The plans are reviewed annually and adjusted as needed as a child makes their way through school. This is just an example of one of the resources we have here in Maryland. It talks through kind of what a 504 plan is, who qualifies, what are some examples of disabilities that qualify, and what are some examples of services or accommodations that might be available. I encourage you to check out any of your state-specific resources that exist for 504 plans and special education. This is just an example of some support, some resources we have in Maryland. Okay, so an individualized education program, an IEP, is kind of the next level up of support for a child in the public school system. And this is supported by the Individuals with Disabilities Education Act, IDEA. Again, it's federal law that's in place to ensure that children with disabilities receive a free, appropriate public education. This is a little bit different than a 504 because this is now providing special education to the child, and the process to qualify for these services is much more intense and much more extensive. So the first step is that a student has to have at least one of the 13 specific disabilities. These are disabilities that have been identified at the federal level, so those are the same 13 disabilities across all states in the United States. And again, we need to have some type of documentation that shows that they qualify because of a disability. And then all of that information goes into another legal document. So the 504 plan is a formal document. This is another legal document, but it's much longer. It includes much more information. I'll talk through that in a little bit. Um, and again, the process in order to get this is much longer. So once a student is identified, and that could be a parent requests them to be evaluated to determine eligibility, a teacher could request that. Ultimately, the parent has to consent to the evaluations to determine eligibility. But once that student is identified, then they're evaluated. Those evaluations could last several weeks where they're looking at things like their academic skills, their IQ. They might do speech and language evaluations. They might do physical therapy, occupational therapy evaluations to really determine how their disability is adversely affecting their ability to access their curriculum in the public school setting. And oftentimes, what schools are looking for is not that just these symptoms are there, these barriers are there, but that is having impact to the degree that they're having difficulty achieving basically grade level educational goals. So we often are then looking at their academic skills, and if academic skills across reading, writing, math are falling below grade level, that suggests that they need a higher level of intervention and support to help support them. So these are the 13 disability categories that are under IDEA. They're listed there in order of frequency. For students with MS, they typically fall under the other health impairment category. We also call that OHI. That's a catch-all category for any medical condition, as well as things like ADHD. So more often than not, a child with MS would be found eligible for an IEP under that classification, OHI. Um, Sometimes patients with MS have other co-occurring conditions like ADHD or a learning disability or autism. So in those situations, they might have more than one category on their IEP that they're found eligible for. But what I always encourage parents is sometimes our patients with MS, once they're diagnosed, they already have an IEP, but that IEP is for a different reason, the learning disability, the ADHD. So I always encourage parents to share the diagnosis with the school so that that can also be incorporated into their IEP because it comes with its own unique set of difficulties and impact on their ability to access the education. So it's important for the school team to be aware of, yes, they might have had this long-standing learning disability, but now there's a neurological condition on top of that that might be making school even more challenging for them. So what is an IEP? So again, an IEP is this legal formal document. And what an IEP is, in addition to that document, is that student's individualized program of special education services. So it provides specialized instruction, and this is where modifications to the curriculum can occur. So if 504 is we're just accommodating, providing access, this says we're modifying the instruction to some degree. This could include some extra support, some intervention to help with reading or math. That could be pulling out of the classroom and getting that support. It could be pushing into the classroom to get that support, which leads into this next part, which is schools and school teams must consider the least restrictive environment. And this is important because some parents hear the term special education and they get really worried that that means their child's going to be placed in a different classroom. They're not going to have access to typically developing peers. And that's not the case. Schools work really hard to keep the child in the general education classroom as much as possible and to give them their supports in that setting. The IEP, like I said, is a very long document, often between 20 to 30 pages. But in that plan, it clearly outlines it's a legal agreement between parents and the school of what type of services that child's going to get, how much of those services, who's going to deliver those services, what are the accommodations, the modification the student's going to receive. And the most important thing on the IEP is there are annual goals that are measurable goals that are created each year to track that child's progress. So, if the evaluations determine that children have difficulties in the areas of reading comprehension and behavior management, then there need to be goals in that area to show what is the school doing to work on those goals and how is that student progressing towards those goals. And IEP teams, which again include parents, meet annually to review those goals, to discuss the student's progress, and to adjust things as needed. Reevaluations are something that not happens, but need to be considered every 3 years. So once a child has an IEP, every 3 years, the team is considering whether that's an appropriate time to reevaluate using some standardized measures to determine if any programming needs to be adjusted. This is just a graphic that again shows the difference between 504 and IEPs. The biggest thing, again, I want to highlight is the difference between accommodate and modify. So in 504, they're accommodations, and in IEP, it's modifying the curriculum and giving special education services. So this might be a question you have as a parent of is what is best for my child? In my experience, most of our patients with MS soon after diagnosis can be adequately supported by just a 504 plan. An exception to this would be, again, if they had a pre-existing IEP due to a non-MS related issue like a learning disability, ADHD, autism, where they already had an IEP in place, they're already working towards those goals, they're already receiving special education, and then we're just updating the IEP. Or if a child has more severe disease that's causing more cognitive and motor impairments, where their level of need in the classroom is higher. But again, most students that I've worked with are generally well supported by a 504 plan. Oops, can you, sorry. Um, and again, it's the school. If you have this question of, I think my child needs more support, and I'm not sure if it's a 504 plan or an IEP, the school will help you figure that out by doing evaluations. You might say, I think they might be considered for an IEP. They do the long evaluation process, and then they determine they're not eligible, then they would create a 504 plan. Or you might just request a 504 plan, get it in place, and then wait and see and how the child does with those accommodations in place. And if they're still struggling, then you might consider that higher level support with an IEP. In addition to those evaluations through school, neuropsychological evaluations can also be helpful because we're looking at a child with MS through a different lens than a school is looking at a child. Because we can help you understand how these symptoms or the impact of these symptoms, how how are they explained by the MS and where lesions are specifically in a child's brain. We can make more objective school recommendations based on what their needs are right now with their MS symptoms, but also think ahead and put in a plan just in case, since we know that MS is unpredictable. But one thing to keep in mind as a parent is that schools aren't required to accept outside testing. So even if you have testing done by a neuropsychologist, schools aren't required to accept that and to consider that. They might want to do their own evaluations to help with this determination. Okay. So as I said, most of our patients are on 504 plans, and that is sufficient to support their needs. Um, so why would one consider that? Again, I think about it for current and future. So if there's current needs, whether those are motor impairments, cognitive impairments, emotional needs, that's obviously an important reason to have a 504 plan, but I also encourage my patients and their parents to consider, well, what about in the future? Should I have another flare up and things might get worse? I want to make sure that something's in place so that there's a plan ready to go and a student's not playing catch up or not sure what to do if they're out of school for a long time. Um, it's more around, I think, the frequent absences, the appointments, if we need to go in for treatment, that it's important to have that open communication with school so that the expectations are clear. I think our patients struggle the most when this isn't in place. Something happens, they're out of school for a few weeks, they go back to school, and now school is making them make up 2 weeks of work. Like you think about the high school level with honors classes. And without a good understanding of these invisible difficulties that Haiwen alluded to is some if a student doesn't have any motor impairments associated with MS, it can be really hard for teachers and staff to understand that they're very fatigued, that they might be having trouble focusing, that they might be struggling with depression because it's just not obvious on the outside. Um, Related to that, I always recommend a 504 plan so that teachers are aware that they know what is going on and they know how to support that student. Um, in addition to that, it teaches the student, the child, the adolescent, to understand their rights as an individual, and how to advocate for themselves and to start that as early as possible, in those teenage years. I think, Krista, this is where you might to point out that with teaching, oh, I think it was a later slide, but the National MS Society is available with resources and to help assist with informing schools about MS and how it impacts, and there's some resources available to help you with that. So now we're going to talk through what are some common accommodations for children and adolescents with MS, based on a number of different things. So in general, for children with MS, we would recommend having access to the nurse's office, permission to leave class if needed. Here's the point about staff training on MS and its impact on a student's school functioning. We never know if and when a flare-up can occur, so I always like schools to have an action plan for when that happens. That could include having a plan in place if a child is going to miss a lot of school for an extended period of time if they're hospitalized. In Maryland, we have home and hospital. In other states, it might be called homebound instruction. That's available for children who are often, it's usually more than 30 days out of school. But there's also something available called intermittent home and hospital for kind of that in between where they might be able to go to school for a little bit, but they might also need some additional support. Um, because they're missing a lot of school. And that's just where a teacher is assigned to come to the home or to meet with a student virtually to supplement what they might have missed if they're missing a lot of school. So to have that kind of standby and on call in an event that a student needs it so they don't get behind, I think is a really important thing to include. Um, we want to make sure that absences are excused if there's hospitalizations or many medical appointments. And again, that there's a clear plan in place to make up work or to excuse mixed work, should students be out. Then if we think about how to support motor impairments, which some students may or may not have, every school has physical therapist and occupational therapist. So they're available for consults. Some schools require that or will only consider that with at an IEP level, but some schools will consider that with just a 504. So it's worth asking about where the school PT or OT will take a look at the child to see how their weakness in their hand might be impacting them in the classroom. Another thing we recommend is having preferential seating near the exit, near accessible areas, just to reduce the burden of having to navigate the school and becoming fatigued. That also includes having access to the elevator, a key to the school elevator. They might need assistance getting between classes. They might need extra time to navigate between classes. I always recommend leaving a class early so they can navigate less crowded hallways to get to their next class. They should be able to have unrestricted use of the bathroom. They might need adapted physical education if they're not able to do the standard PE curriculum. And then this is a big one for some of our patients that have weakness in their dominant hand. So if they're right-handed and they have weakness in that right hand, school can become very difficult because of all the writing and typing that is required, especially at the high school level. So some accommodations to support that is having copies of notes from teachers so they don't have to write as much, or they have someone taking notes for them. They can have a scribe, so a human who is writing their answers for them. They might be able to use speech to text software where they're talking and it appears as on text for more, computer work. Having access to computers, sometimes typing is much easier than handwriting, and overall just reducing the amount of written work that is required. Fatigue is a big thing that our patients struggle with, and the school day can be very cognitively demanding and exhausting. We recommend having an identified place in the school where a child can go to take a rest break or a nap if needed. At the high school level, when high schoolers are scheduling, we like to be creative about how they're scheduling their classes. If they're more alert in the morning, it might be beneficial to schedule the most important core classes then. Or if they have trouble waking up in the morning and need a later start, then they might want to schedule their most important classes towards the end of the day. Students might choose to have a shortened day or a modified day. So at the high school level, where they might only need a couple credits or those core classes, instead of having to be there for electives all day, we can shorten or modify that day. And then again, a long school day makes someone tired, and in the afternoon after school it can be really hard to complete homework. So another accommodation that's available is to reduce the amount of homework a child has to do in the evening when they're tired, or to give them extended deadlines to complete that work. Vision is something that impacts some, but not all, patients with MS. And here's just a list of some of the visual accommodations. Again, preferential seating so they can see the board more clearly, and then a number of different things to help magnify text. You can get copies of books with large print or high contrast, audio versions of everything with technology now. That's a really easy software add-on on their Chromebooks, or audio book versions that you can get from the library, but the school will have access to all of these. If the work requires a lot of visual scanning, reading, worksheets, to take some breaks with those and allow those breaks in the classroom to reduce how much is on a given page. So a lot of math problems might be overwhelming. So maybe having a worksheet that has half the number of problems on it. And some patients like colored overlays that can go over um, worksheets to reduce that visual strain. Mental health, we talked about depression is not uncommon in patients with MS, and there's support available within the school setting as well. So every school has a school counselor. It might be helpful to have scheduled meetings so that a student doesn't feel like they have to ask for it, that it's just kind of there and routine and that they're checking in. A flash pass is something that a student can have. So instead of having to describe why they need to leave the room, if they feel like they're overwhelmed or upset, they can just non-verbally show a teacher a flash pass and then go and have a quiet time to themselves somewhere else in the school. We also encourage staff to monitor for bullying or isolation, um, and as much as possible, or if available, providing structured peer interactions or social groups to help students feel connected. And finally, the accommodations to support cognitive functioning. Some of these overlap with the ones we've already talked about, but I tried to include just ones that would be more for the processing speed difficulties, attention, and memory. So extended time, I feel like every child that has a 504, that is an accommodation that they have. So for test assignments, they get time and a half or two times. Having access to notes, we already talked about. Reduced work, we talked about. Preferential seating, this time not for vision, but to keep them focused at the front of the classroom. Teachers helping them chunk their homework. So this would be for executive functioning difficulties if they have trouble planning and organizing, if they need reminders while they're in the classroom due to distractibility, if they have memory difficulties and have a hard time remembering information, teachers might help them retrieve it, give them word banks for exams. Um, Access to calculator. Sometimes we think about this only for students who have math problems, but it's also important for our patients with working memory because to solve algebraic equations and calculus, a lot of working memory goes into solving those multi-step problems. So to have access to a calculator that really kind of reduces that working memory load. Again, to help with executive functioning, planners, organizers, open book exams to help with memory difficulties. These are all examples of what you could ask for to be put into a 504, depending on your child's individual needs. Then, as we get towards the end of high school, we start thinking about standardized tests. And what I just wanted to highlight here is that this is a different eligibility process than just your school-based 504 and IEPs. So this requires separate documentation of disability, a separate application, and it takes time. So I encourage students and parents to plan ahead for these. Your school teams can help you with them, but again, it's separate from their 504, their IEP. I put the website in there for College Board, who administers the PSAT, the SAT, and AP exams. And I listed some of the most common accommodations that you can ask for. And these are all clearly outlined on their website as well. So again, the most common one is extended time, whether that's time and a half or 2 times. They can request additional breaks or longer breaks to help with that fatigue and stamina. They could have, for vision if issues, someone read it out loud, the text to speech, enlarged text. And again, that use of calculator can be helpful. And then at the college level, again, every college and university in the United States has to have something in place to support students with disabilities. And this is supported by the ADA and the Section 504 plan or Section 504 Act. Every college calls it something a little bit different. And I encourage students who anticipate that they would need some level of support to ask about these things when they're looking at colleges and to really get a good sense of what services are offered because there's a lot of variability between schools. But I would search, if you're Googling for a certain school, search for the word disability office. It might be called the Office of Access and Accommodations. It might be called Disability Resources. Every school calls it something different, but every school has an office like this. Um, Similar to the college boards, you need documentation to show that the disability exists. Oftentimes, they want a copy of the child's 504 IEP plan from high school. Sometimes they require a recent neuropsychological evaluation within the past year and require specific tests and scores to look at to determine eligibility. And again, you're always going to need a signature from a physician or a psychologist to document the disability. Really important to plan ahead for students starting freshman year in the fall. Oftentimes, these forms need to be in the springtime or early in the summer. So it's important to research this early on because once the semester starts, it's hard to get these things in place because it is a process, and those forms often have to be reevaluated and resubmitted every year. A lot of the accommodations at the college level look the same for the classroom and for testing, so I'm not going to go into those as much. But for a lot of students, they're living on campus, and that's a whole host of new accommodations that are needed. And these are really more to support any of the motor impairments associated with MS. So you can request a dorm room on the ground floor. You can request a single room or an accessible dorm room. I'd be thinking about if dorms have elevators. Some of these dorm rooms or dorm buildings are very old without elevators, but which one on campus does have an elevator and is that needed? You can request dorms that are closer to the main parts of campus to reduce the amount that the student is walking from the dorm to the classrooms, the dining halls, and other campus services, and also inquire about what parking options are, since parking lots can vary with, again, how close they are to the dorm rooms and other services. Classroom accommodations, again, I'm not going to go through it. It's very similar to at the high school level. And for testing, often what this looks like is being able to take exams at another location and with extended time. So they're going to the disability center and taking the test without anyone around. They can really focus and they can have twice as long. Some other supports that are available at college outside of just the specific plans that students might have is a lot of colleges and universities have tutors for specific courses. They have writing tutors and they have learning centers where they offer lots of different courses on how to manage college coursework. They might have assistive technology labs where college students can learn how to use software to help support them, like text-to-speech, etc. All schools have mental health services available, which I would strongly encourage to look into. They might have a peer mentoring program, which help them feel more socially connected on campus. And every undergrad will have an academic mentor. And I really encourage my college students to connect with their mentor in addition to just their course professors to be open with them about what their needs are and to advocate for themselves so that they are as successful as possible in their college career. And that is it. So I'll hand back over to Krista.
Yes, thank you so much to both of you. I found that really informative. I loved the way you shared with us more about kind of the biological um, reasons that people often need accommodations and some of those really tangible examples of accommodations that can be requested. I think that's really helpful for all of us to think about. I do want to share some additional resources, some more general resources if you're not already familiar. We've talked a lot of about tonight about the best accommodations for school, but the society is here for you through all the other things in life, each new change that you go through with your MS. And the best place to learn more is on our website at www.nationalmssociety.org/pediatric-MS. There you will find our Pediatric MS Resource Guide, which has a comprehensive list of helpful resources for families affected by pediatric MS, information about additional organizations that support youth and teens with MS and their families, financial resources for families impacted by pediatric MS, our Find Doctors and Resources tool, which helps you identify providers close to you, like Dr. Jones and Dr. Chen, ways to engage with our advocacy efforts, volunteer opportunities, and events like Walk MS, and much more. And if there's ever a time when you have questions or need additional support or just can't find something on our website that you're looking for, you can contact an MS Navigator. The Society's MS Navigators are very skilled, kind professionals who can help you work through the challenges and changes with MS based on your personal experience. Some resources that MS Navigators provide include emotional support resources, access and referrals to MS healthcare specialists, support working through health insurance options, benefits, employment resources, wellness strategies that can make an impact on quality of life with MS, and much more. They can help you figure out what you need and how to talk to the right people to get it. You can talk to an MS Navigator over email, by direct message on our website, or you can call 1-800-344-4867 to learn more. They can help both parents and kids and give you helpful resources for your whole family. But if you are a young person who wants to talk with an MS Navigator, please make sure to check in with your parent or guardian first. If you're interested in connecting with others who can relate to what you're going through, I would encourage you to join one of our groups available to only those affected by pediatric MS. Teens can join our MS Youngsters group that meets virtually on a monthly basis and is led by a society-trained volunteer. You can also follow them on Instagram at MS Youngsters. Parents are also invited to join our group just for parents of a child currently 25 or under who has an MS diagnosis. You can find more about both these groups on our website. Thank you again to our speakers, and thank you again for joining us for our Pediatric MS Navigating Your Journey program.